morning, and thank you for giving me this time. So in session one, we really wanted to have an overview of EHRs in oncology, what some of the accomplishments were and what some of the challenges were. So we covered a lot of territory. We did say at the beginning, just to remind people, that in fact EHRs are a good thing, that they're much better than where we started when I started my career with paper records. And they've evolved a lot over the years, but maybe their full potential has not been realized, and we need to think about that. They started as tools for scheduling and for billing and for data storage, but their role in safety has evolved, sometimes in good ways and sometimes in not such good ways. We acknowledge the fact that cancer care is very complex, and in fact EHRs are very complex, and that EHRs, particularly those in matrix organizations, serve many constituencies. And that makes combining the complexity of cancer care and the complexity of EHRs a challenge. We also said, though, that we needed to have a focus on safety and efficiency, and we've not done as good a job in those regards as we might have over the years. Critical data needed to be displayed more clearly than it currently is now, and it needed to be unobstructed by less needed data. And this, by definition, is going to be different for different specialties. So there has to be some customization for cancer care. Patient-centered communication is a foundation for patient empowerment and trust. And while medical records and EHRs have served primarily the medical providers, they now clearly also serve the patients, and they need to be viewed that way. And we need to remind ourselves that the medical information in EHRs belongs to the patient. There needs to be a triangle of trust between the patient and the clinician and the EHR, and that's a real triangle. It's not an imagined one. EHRs must also support equity of care and not inhibit it, and language must support that equity and avoid stigmatism. And along with that, there are challenges to bring social determinants of health into EHRs in ways that are both appropriate and useful. EHRs are a trove of data, but most of that data is in unstructured format and needs to be standardized, and quality and research are closely linked. EHRs also can give us a remarkable window into real-world patient data and evidence, and we need that badly for many, many reasons, and we need it in ways that we can access it quickly, and the COVID pandemic was a very, very pointed reminder of this. And interoperability is key and needs to be expanded. Next slide, please. There we go. So just a couple of things to emphasize in my last few moments. We should reimagine, reevaluate, and reconceptualize what EHRs need to do well for the clinician and for the patient. This should be the primary focus. It's not what the clinician needs to do for the EHR, but what the EHR needs to do to serve the clinicians and the patients. EHRs have the ability to facilitate clinical experience and patient experience in their interaction, or it has the ability to thwart both. And we need to evaluate how EHRs are working scientifically in regard to its support and not of these goals. Quality and safety depend on how the EHR functions, and steps need to be taken to better optimize functionality in this regard. I think we're not where we need to be in this regard, and we need to have focused work on this. EHRs are a product of continual evolution. We continually add to it, but we also have to shed parts and functionality that are no longer necessary, and we need to have only what's important there, and that's not where we've ended up. Standardized and structured data will facilitate usability, decision support, quality, and research. We're not where we need to be with standardized data, and we need help from regulators and from payers in this regard. There has to be a national will to drive adoption of standardized and structured data incorporated in EHRs as routine care, as well as enhancements to interoperability through regulation and payment incentives and requirements. It's not going to happen by accident, and we need to all get together as a medical and oncology community to push us in this direction. Thank you.